Good afternoon. We are starting the sixth session on control of neglected diseases and social determinants of health. I would like to begin the session by welcoming the session chair, Mr. Sunil Nandraj, and session co-chair, Dr. Werner Soers, on the dais. I begin by introducing the chair, Mr. Sunil Nandraj, who has been working in the field of health and development for the past 25 years in various capacities. He has worked for 11 years with the WHO India Country Office as Cluster Head for Health System Development. He is a senior advisor at the Public Health Foundation of India, New Delhi on universal health coverage, and also an advisor to the Ministry of Health and Family Welfare, Government of India on regulation. He is engaged in providing technical assistance for operationalizing universal health coverage in the state of Karnataka and Kerala. He is presently on a sabbatical and is involved in setting up a website called Media Leaks on the lines of WikiLeaks for documenting irrational practices and irregularities in the health sector in India. Last but not the least, he is an old friend and well-wisher of IPH. Welcome, sir. I now introduce the co-chair, Dr. Werner Soers. Dr. Werner Soers graduated from the Medical School Antwerp University in 1986. For the next 17 years, he worked with the rural poor in Nicaragua, Central America. He joined the Public Health Department of Institute of Tropical Medicine in 2004 and since then has researched and taught on community health and social determinants of health. Currently, he is involved in a European Commission-funded project called Health Inc., which studies social exclusion from health protection schemes. He is also pursuing his PhD in social science on social exclusion of Dalits and Adivasis in Mysore district of Karnataka. Welcome, sir. I welcome our panelists, Ms. Devaki Nambiar and Dr. Rupendra Bojani on the dais. Welcome all once again. I now request the chair to take the session ahead. Thank you.
Thank you, madam. Welcome, ladies and gentlemen, to this session, and I hope it's going to be exciting, and I'm sure that you will make it exciting. If not, I and Werner will see to it that we'll make it exciting. It's a panel discussion, and we plan to conduct the sessions where the panelists would present 10-15 minutes on the issues, and then we open it up for clarifications, and we hope to make it as participatory as possible. Now, to introduce the topic in terms of the issues, the topic area is control of neglected diseases and social determinants of health. The issues that one needs to look at is with regarding to the disease burden associated with these applications, which remain high, addressing the issues of water sanitation, household-related factors, environmental risk, migrating population, social cultural factors, gender, and last not the least, poverty. We are also looking at in terms of whether it's targeted public health interventions in the absence of drug or vaccine breakthrough, the entire issue of biomedical disease model, focusing on drug or vaccine breakthrough vis-a-vis focusing on social determinants of health. We are also looking at, in the context of various ministries of health and other ministries, their convergence, their issues, what happens. And with this, I just would like request my co-chair, Dr. Werner, to say a few words with regarding to the broad contours of the topic.
Good afternoon. Good afternoon, all of you. You might rightly ask, why, for Christ's sake, a session on neglected diseases and social determinants? Or you might not ask so, as 2 days ago you heard Professor Marleen Boelart's inauguration speech. spelling out very clearly that neglected diseases are first and foremost the poorly controlled diseases of the poor. As she spelled out, and several presenters did later on in the state-of-the-art sessions, in the Indian subcontinent, that means the diseases that disproportionately affect the so-called lower castes. For neglected tropical diseases, this unfair relationship is even clearer than for general health problems. This alone, we think, is enough reason to pay attention to social determinants and neglected diseases in tandem, to go beyond the needed technical interventions, to go beyond even mere access problems, and to aim at the social context, the agents, and the mechanisms also. To put it in a kind of a black and white metaphor, it is not because there is no entrance fee for the temple that the Dalit will be allowed to enter the temple. In the same vein, it is not because we make diagnostic tools and effective treatment freely available that Dalits and Adivasis and other socially excluded people, for that matter, will benefit automatically from our advanced state-of-the-art. That's why we need to talk social determinants also, so that you can make a change. As you know from the program, we had 4 panelists. First of them was Professor Frambaum. Professor Frambaum is director of the Southgate Institute of Health, Society and Equity and of the South Australian Community Health Research Unit at Flinders University, Adelaide, Australia. She was member of the historic Commission on Social Determinants of Health, 2005 to 2008, and is also co-chair of the People's Health Movement Global Steering Committee. Within her long academic and teaching career in public health, Professor Frambaum has not only advanced and spread knowledge on social determinants of health and health inequities, she has also actively contributed to effective government and community response to social determinants of health inequity and social exclusion. In Australia first, and then globally, from the grassroots of Aboriginal health up to the launch of health in all policies. It was thus an enormous honor for us when Professor Frambaum accepted to be keynote speaker at this colloquium. Unhappily enough, bureaucracy decided otherwise, and she was denied her visa. Luckily enough, she recorded her presentation, which we will present now.
Good afternoon. I'm really glad to be joining you virtually at least, if not in person. And I'm sorry I can't be there in person. It was a problem with my visa. And thanks very much to the organisers, and particularly Werner Saul, for the invitation to join you in the colloquium, and I hope it's going really well so far. My basic argument today is going to be that neglected diseases are no different to other diseases in that we need to pay attention to more than the tip of the iceberg. Most of our focus is on the tip of the iceberg, and we ignore what is below the surface, despite its importance in driving diseases and risky lifestyles. So the tendency is to focus on the visible manifestation of disease and not to look at the underlying factors such as daily living conditions, where we live, what jobs we have, what social support we have, how safe we are in our communities, and the even more invisible factors of social and economic factors, local, regional, national, global, and issues such as the distribution of power and wealth, and of course gender and class. Just to start with, I don't think this will be news to anyone, but just to have a look at how health is distributed globally, we can see that if you're born in Africa, you have about half the chance of, you live for half as many years long. You live just over 40 years compared to just over 80 if you were born in a country like Australia. So inequities are part and parcel of our world. We can also see in terms of infant mortality rates that if you live in a high-income country, you're much less likely to die in the first year of life than if you live in a lower or middle-income country. Similarly with maternal mortality, having a baby is much safer in high-income countries than in low-income countries. And in terms of injury, there's also a gradient with some countries like Indonesia, like Sri Lanka, having really high rates of death by injuries. If we look within countries, we get similar gradients. So looking here at Kenya, we can see that if you live in an informal settlement in Nairobi, under 5 mortality is far, far, far higher than a high-income area in Nairobi. And similarly, if we look at under 5 mortality rates, according to urban wealth quintiles, there is again a gradient. Pretty, not always exactly in Egypt, it's slightly different pattern, but generally there's a gradient. If you're poorer, you stand a greater chance of dying when you're under 5 than if you're richer. And each of the groups in between also reflect a stepwise progression. So the policy objective clearly is to level up the whole population to that of the richest group. You could achieve equity by levelling down, but I don't think many people would argue for that. So always what I'm interested in terms of policy is how can we level up. I spent 3 years working on the Commission on the Social Determinants of Health from 2005 to 2008. Our report was launched by Margaret Chan in August 2008, and when she did so, she said health inequity really is a matter of life or death, and that really drove the findings of our commission. Our headline recommendations were that we need to improve daily living conditions, we need to tackle the unequal distribution of power, money and resources that underpin health inequities, and we need to measure health inequities, understand the problem in detail, and assess how well we're doing at reducing inequities. So those are the 3 headline factors, and we use those, a group of colleagues that I worked with through Asia Pacific Health Gain, use those 3 factors to work out an action framework and showing how each of those is really related. And what I want to do today is just dig down into some of those and explore in a bit more detail how we can take action on the social determinants of health. So the 5 things I want to look at are, first of all, to improve the quality and type of health service and focus particularly on comprehensive primary health care, to look at labour and social protection and wages and conditions, to consider urban areas, urban planning and governance and how important that is, to have a look at how we can bring about effective intersectoral action. People have often talked about the need for intersectoral action. And finally, to look at macroeconomic policy, particularly tax and trade. So to start with the health services, the Commission recommended that if we're interested in health equity, we should have publicly funded health services that guarantee universal health coverage for the whole population, and that the workforce should have a good understanding of social determinants and have the capacity to take action and recognise their importance, and that consequently social determinants should be part of the training of all health professionals, doctors, nurses and others, but also people such as urban planning. We really need to spread the message about social determinants of health. And our model for the health system is that it should be based on primary health care, should enable locally organised action on social determinants, and that the primary level of care should of course provide treatment, but it should also focus on prevention and promotion. Now, primary health care as a basis of a health system has long been argued, and we know that the comprehensive approaches to primary health care stress the need for community participation, for multidisciplinary healthcare, for health promotion and disease prevention, to use appropriate technology to a particular setting, to focus on achieving equity, doing that levelling up through the health system, to develop social understandings of health. And in the 1970s, when Alma Ata was developed, there was a strong emphasis on global cooperation and peace, and saying that if we invest in health rather than armaments, then there is enough money to achieve health and social security. And of course, that original call for primary health care went along for a call for a new economic order, and I'll talk a little bit about that later. I think it's worth just stressing the difference between selective and comprehensive primary health care, and here I've chosen the example of diarrhea. A selective approach would, of course, manage diarrhea. It would use oral rehydration therapy. In terms of prevention, it would stress breastfeeding and measles vaccination. But a truly comprehensive approach would go below that surface, go to the base of the iceberg, and focus on providing clean water, good sanitation, and household food security. The next thing I want to look at is about reducing the adverse impacts of work. Work is good for our health. It's good to have a job. But in some cases, work can be harmful if it's unsafe, or if it's a case of child labour or unsafe conditions. And we argued on the Commission that it's really important to empower workers and communities to protect their own health and well-being, and to ensure that work quality is seen as a central part of social policy. Now, this includes establishing enforceable labour standards that has mechanisms to enforce those, and ensuring that workers are covered by universal health care, social security safety net for workers and their communities. And importantly, to ensure that those who derive economic gain from work arrangements are also held accountable for the adverse social and health consequences. So there's a real need for regulation of work and workplaces and employers, and ensure that that people's health is protected when they're at work. Along with work goes the importance of social protection. Social protection fulfills people's basic rights. It establishes a very firm platform for both economic and social development. It's a great stabiliser for vulnerable groups in times of crisis. And it really needs to be both institutionalised, based on entitlements, not charity, and provide universal access to the services which strengthen people's capacities, such as health, education and nutrition. Now, universal policies are generally good for equity. They avoid two-tier services, and then the middle class have a real vested interest in the quality of the service, which they don't if they're buying from a privatised service. And within universal provision, you can target, and that's been referred to as proportionate universalism. And of course, universal policies are very good for social solidarity. We argued in the Commission report that it would be possible to have a basic social protection package for every citizen on the earth. And here you can see how much that would cost of gross national income for age pension, child allowance and healthcare. And we certainly have enough resources in the world to do it. It's just a question of how we distribute them. Just one example from Brazil, a conditional cash transfer program which reaches about 25% of the Brazilian population, that's 52 million people. Cash is paid mainly to the females in the family, and it is conditional on certain behaviours: school attendance, prenatal care, vaccination and health and nutritional surveillance. And that in itself is controversial. There are debates about whether these cash transfers should be conditional. The evaluation of the Bolsa Familia programme suggests that it's contributed significantly to reducing economic inequities in Brazil. They've been dropping consistently in the last decade or so. And for the families who receive the cash transfers, it seems to result in improved food security, less school absenteeism, and the children are more likely to have a normal height for age. And of course, those things are setting those children up for much better health in later life. So it's a great investment. The next thing I want to look at is thinking about urban areas. And of course, informal settlements are a big problem across the globe. One of, I think, the great initiatives that's really been undersung in the last 20 or 25 years has been the Healthy Cities Programme, which WHO started in the mid-1980s. And it has spread around the globe, and city governments all around the world have been inspired by healthy cities to take actions to promote the health of their citizens. In East Asia, we have an Alliance for Healthy Cities that has members from Australia, Cambodia, many other countries in the region, and it's really about reaching for the highest possible quality of life and equitable distribution of life by promoting and protecting health in all settings in the city, whether that's about healthy markets, healthy hospitals, healthy workplaces or healthy schools. It's about saying that the environments in which people live in our urban areas are absolutely fundamental to their health. WHO, since the Commission, has also produced an Urban Heart Health Equity Assessment and Response tool, which is about identifying and analysing inequities between people who live in different parts of cities or belong to different socio-economic groups. But it's also about facilitating decisions on what's viable and effective, what can be done about the health inequities. It emphasises a set of core indicators. I've just got some examples here. So in terms of health, it might look at infant mortality, diabetes, TB and road traffic accidents. And then for those 4 sets of social determinants, the physical, environment and infrastructure, social and human development, economic and governance, there will also be a set of indicators. And then those can be used to compare, for instance, neighbourhood in a city, or you could compare different cities, and the red spots are identifying where there are problems, and the green are where things are better than average, and the yellow, I think, are where they're about average. But you can see how that can really direct the attention of policymakers to then develop strategies to deal with those health inequities. And urban health is increasingly important as more and more of us live in cities. Now, one of the important factors about social determinants is how do we create action across sectors? And I think health in all policies is one of the interesting things that has developed in the last decade. And it really asks, how do we create health and well-being in a systematic way? And it really tries to seek synergies between health and other sectors. And it's about making policymakers in all sectors accountable for their health impacts. And I think when we think about implementing health in all policies, it really is about establishing mandates for the action, establishing structures to oversee the health in all policies, processes and tools. So mandates might be laws or state plans, structures will be the committees that are established or could be merging ministries. Processes are policy dialogues or public health reporting systems, and tools are things like health impact assessment or support for joined up working or joint budgeting. The important thing is that these should be implemented across government. This just isn't about the health sector. In the town I come from, Adelaide, and the state of South Australia, we have a Health in All Policies initiative that is directed by the Premier and Cabinet Department. The health sector is really the catalyst, and it puts a lot of emphasis on understanding the political and bureaucratic imperatives of other sectors, and is always seeking a win-win. A win for the health sector in terms of promoting health, and a win for the other health sectors in terms of how they can promote their goal. The main strategy used is the health lens analysis, which the Health in All Policy unit uses to look at new public policy areas and to see how their health and well-being outcomes can be maximised. They're always at great pains to ensure that the core business of the other sectors are taken into account, and that their sectoral goals can be achieved as much as the health goals. And I think it's worth stressing that if that health in all policy approach works, then it has many benefits. It leads to a healthier population, which is good for employers, it's good for education, it's good for social interaction and parenting. Generally, the health in all policies is highly compatible with low carbon and sustainable futures, which is good for all of us. It produces a lot of economic benefits, And eventually it should lead to lower healthcare costs because people will be healthier. And that means those funds can be invested in other sectors that can be used for measures that support communities in a kind of virtuous cycle. The final point I want to look at is about microeconomics, because as we've seen, we do need a new economic order to promote health. And I just as an example, want to look at the way that trade liberalisation is having an impact on our health and consider whether, as a social determinant of health, we have to consider ways in which the global economy can be made more health promoting. Liberalisation of trade threatens affordable medicines, which I'm sure at this conference you've considered the importance of affordable medicine for all sorts of diseases. It can also threaten a whole lot of public health measures, for instance tobacco control. So at the moment Australia's introduced plain paper packaging of cigarettes, and yet they've been taken to the World Trade Organization by the tobacco companies saying that this is an infringement on free trade. So far that hasn't been upheld, but nonetheless it might be a disincentive to other governments taking that up. I think there's also an increasing amount of evidence that the liberalisation of trade has distorted the food supply in many countries. It's led to the import of high fat, high sugar, very highly processed foods, which are a lot less healthy to people, and are fueling an epidemic of obesity, which in turn is leading to a range of chronic diseases, not least of which is diabetes. And then finally, along with liberalisation of trade, has been a reduction of taxation. Large corporations have found more tax havens, and that results in less dollars for health and social spending. So I think one of the big advocacy tasks for all public health practitioners is about increasing the fiscal space for action on social determinants. Taxation is important to enable governments to take actions. The revenue for social and health development and universal health care is essential, and taxation is the way that governments can get money to spend on those things. Tax can also be a great mechanism for redistribution. It can reinforce citizenship. It can also be used to shape healthy behaviours by repricing products such as tobacco and high-fat, high-sugar foods. And in the Commission, we recommended consideration of an international financial transaction tax, such as the Tobin tax, to provide funds for the social determinants of health. And it's pleasing to see that the EU is moving to introduce such a tax. If we did that globally, it would free up billions, possibly trillions of dollars, with which we could move to ensure much better social security and health care for all citizens of the globe. So I think taxation is an essential issue for public health. Finally, I want to think about how will we bring about the changes that will ensure that we do have healthier societies in which the social determinants work in favour of health rather than against health. And I conceptualise this as a nutcracker, where we have top-down policy action that's brought about by bottom-up community action. And I just want to give two examples of civil society action. One is the Asia-Pacific Health Game, which I've already mentioned. It's a group of policymakers, civil society people and academics who are advocating for improved research, training and policy for health equity in the Asia-Pacific region. In 2011, we produced a report on health equity and social determinants in the region, and we're also doing some training, knowledge generation and advocacy. So look at the website if you want to know more. And finally, the People's Health Movement. I've been active with the People's Health Movement since it was formed in Sabah in Bangladesh in 2000. I've been a member of the Global Steering Committee for some years. I was co-chair for a number of years. And we really focus on the social, economic and environmental determinants of health. We're a strong global network for health activists. We run a series of courses on the political economy of health under the International People's Health University. We produce the Global Health Watch, and we perform watching of WHO. So we're at the World Health Assembly, at the Executive Board, looking at the action that they're taking on social determinants of health. And we have a number of circles on topics such as extractive industries, employment and health, universal healthcare. So please also look at our website if you're not familiar with PHM. So just to summarise, I think the social determinants are what is lying below the surface of all diseases, including neglected diseases. And I think we really, if we want to improve all diseases, then we really need to focus on people's daily living conditions. And just as importantly, we need to look at the economic structures that maintain inequities both between and within countries. That change is going to require strong government policy action, and that action is most likely to happen if there are strong civil societies and communities arguing for that action on the social determinants of health. So thank you very much. I hope the colloquium's going well. I'm sure you're having great debates and discussions, and I look forward to hearing much more about that. Thank you very much, and good afternoon. Good afternoon. I'm really glad to be joining you virtually at least, if not in person, and I'm sorry I can't.
From Baum again. As Fran is not physically with us, but actually in the air, flying over Bangalore on our way back from London to Adelaide, we do not have the opportunity for questions and comments right now. But thanks to our IT and social media colleagues, we can invite you, however, to comment and question all evening and all night long. You have three possibilities. You can post your comments and questions, one, on the Colloquium blog on the website. Second, you can do it if you, like us, are not tech savvies. You can do it on paper, on the comments board out in the hall here, and then it will be transferred by us to the blog. Or you can do it on the dedicated space in the closed group Facebook page of the Colloquium. In any case, tonight Fran Baum will read it, and she will respond tomorrow at 8:30 on Skype here in the hall. I think that is well understood. Mr. Chair.
Thank you, Dr. Werner. Now I would like to invite the panelist, Dr. Devaki Nambiar, who's a research scientist at the Public Health Foundation of India, New Delhi. She's done her PhD from Johns Hopkins School of Public Health, and she's been working in the area of health for the last 10 years, mostly in Asian and also other African countries. She's been a core member of the Technical Secretariat for the High-Level Expert Group on Universal Health Coverage, which PHFI led. She is a lead on the Social Determinants of Health chapter, and it connects to her prior work on social inclusion and health, community participation, and other related areas. She's a member of the Medico Friends Circle, the APHA, the American Anthropological Association, and lastly, she's a passionate person. I've just started working with her. She's passionate about her work, highly technical, and writes wonderfully well. I enjoyed one of her papers, which is an ethnographic paper on health policy making, and I look forward to hearing from her. Thank you.
Thank you, Chair, for that extremely intimidating introduction. I was worried already that I had to follow Dr. Baum, and now you've made it worse. Thank you. Let me start off by saying that I'm very humbled to be part of this panel and also grateful for the invitation to join you all here. I'd like to thank the Institute of Public Health for their very patient secretariat duties, and also for the partners who've helped put this meeting together. I'm also very glad to see a panel on the social determinants of health, and I hope to sort of explain why as I go along. So full disclosure, I've been a little selfish in preparing my comments for this panel. I took the opportunity to talk about something I've long wanted to talk about, and that has a sort of personal tenor to it. And therefore, I decided I'd prepare a script rather than a presentation. Also, Sunil challenged me not to have a PowerPoint, so with due apologies to those of you who are expecting slides, I'll be reading my presentation out. So let me get started. I'd like to start by talking to you all about Manoj. Manoj Kandher used to work at my organization, the Public Health Foundation of India. He joined our family in 2011 as a health communications specialist working specifically on a tobacco control project called STEPS. Manoj brought 7 years of experience in development communication, and he had worked with noted institutions like the Population Foundation of India and the Odisha State AIDS Society in his native state. I had occasional interactions with Manoj in the course of organizing our weekly research seminars at our Vasant Kunj office in Delhi. Manoj's office was in City Fort institutional area some 20 minutes away, but he would still attend the sessions he could. Paying attention to communication, to community, these were the kinds of contributions Manoj made to our organization. On 30th October 2012, we received an email from the head of HR informing us that Manoj was no more. He had succumbed to a snake bite 2 days earlier, that past Sunday. A Sunday he had been spending holidaying with his 3.5-year-old. My mind boggles and then numbs at even the recollection of this tragedy. You immediately start thinking about all the reasons why this is an anomaly, not the norm. There are, in fact, reams of peer-reviewed literature describing prevalences, propensities, and modeled calculi of risk and vulnerability that identify a very different victim of snakebite. According to Mahapatra and colleagues' work as part of the Million Death Study in India, snake bites tend to occur most often among rural agrarian males aged 15 to 29, most often in the state of Andhra Pradesh, in the monsoon months of June through September. Manoj is an urban health interventionist, aged 35 to 40, envenomed in Odisha in October. He is a standout among the 45,900 estimated Indians who annually lose their lives to snakebite. Snakebite is, as we know, in the, quote, other neglected conditions, end quote, subcategory, along with 17 tropical diseases nested in what I feel is WHO's curious and somewhat masochistic nosology of neglected diseases. Detailed information about these conditions and diseases of poverty as they are known in international discourses have been getting particular attention recently. Perhaps all the more so as the shadow cast by the big three, HIV, TB, and malaria, changes shape. But there is a larger political point being made through this categorization. Our gross neglect of snakebite and other events and diseases like it serve to make each of us more vulnerable. Snakebite and other neglected diseases are not merely diseases of poverty, no more than any disease or condition can be of poverty. I would like to argue that, whether rich or poor, we are all vulnerable to neglected diseases, precisely because we neglect them. This has in part to do with what we focus on in public health. The current focus of public health research and praxis tends to oscillate between two orienting notions: individual vulnerability and structural determinants, or for some, structural violence. How these two poles are linked, the meso level, or the middle ground, as people like Parker, Hopper, Hirsch and others call it, is less well understood. I like to think of this middle ground or meso level as the social level. Take, for example, the two prongs of WHO's advised recourse to snakebite. 1, reassurance and immobilization, and 2, immediate referral to an equipped hospital. Certainly these features may be a near impossibility for a subsistence farmer in rural Andhra, but as we tragically learned in the case of Manoj, they are not guaranteed for anyone. Manoj is from Tuapali village in Barga district. This is where he went that October. It was puja season, and he was, like many of us, home with family. He had gone swimming in a canal and noticed that he'd been bitten. Not wanting to alarm his daughter, he dropped her home on his motorbike and went to a nearby hospital. Already, the requirement of reassurance and of immobilization is breached, because quite frankly, it was impractical in his case. Manoj reached this hospital only to realize there was little help he could get from there. I learned at a condolence meeting about a year ago that this private facility had little idea of how to deal with snake bites and certainly no access to antivenom. To their credit, staff at this Tuapali hospital referred him to VSS Medical College and Hospital at Burla in Sambalpur district. This was over 40 kilometers away. Manoj chose to try to go to a hospital in Remunda, about a tenth of the distance, 3.5 kilometers, much more manageable, seeing as he was on his motorbike. But Manoj lost consciousness en route. The second cornerstone of immediate referral to care is violated. Locals who found him had the sense to rush him to a private nursing home. The nursing home physicians again referred him to Burla. This is 40 kilometers away from Remunda, or worse, 65 kilometers away if you use the state highway. The Good Samaritans who were helping him proceeded to travel 47 kilometers to take him to another district, Barga district, headquarters hospital. The trip would have taken about an hour or so. Manoj didn't survive far beyond this last trip. Our health system has failed Manoj. And by extension, as members of the public health community, we shoulder some of that responsibility. In contrast, I am struck at the persistence and intentions of those who at the most acute of times were by his side and trying to make recovery possible for him. Our neglect then is most certainly manifest in the health system's incapacity to address snakebite, but we also neglected the possible role for communities in a snakebite-prone area to more expeditiously and effectively access treatment. Did the Samaritans know that antivenom should be available at the nearest PHC? Did any of us? Mahapatra and colleagues have indeed highlighted in their 2011 study the need for improving community education to reduce the incidence of snake bites and speed up the transfer of bitten patients to medical care. But shouldn't we be going a step further? Gutierrez and colleagues in their PLOS piece introducing the Global Snakebite Initiative this June noted, and I quote, that snakebite mainly afflicts low-profile rural populations that lack a political voice. Victims cannot influence regional and national administrative and political policymakers, and their needs remain largely unheard and politically neglected, end quote. But on the ground, it is these low-profile rural populations that exercise agency, care, and compassion for victims of snakebite. At the very least, should we not be enabling them? As is well known already, the very nature of neglected diseases is that they will occur in constrained, remote geographies where already health supplies, infrastructure, and human resources may be scarce. Does this not require an altogether different strategy? Snakebite has been deemed India's most neglected tropical disease. Indeed, it is neglected among the neglected, only entering the global policy fray as recently as 2009. Current strategies of surveillance, treatment, and education follow a well-rehearsed public health mantra, but we can think about alternatives, I think. In the context of this session, what can an SDH view on this issue open up? In my understanding of SDH, the element of the social is key. That is, social determinants have to do with the social relationships of people to institutions, processes, and each other. This may well be a neglected dimension of the SDH discourse so far, but that is a topic for another talk. With specific reference to snake bites, Gutierrez and colleagues in the piece I earlier mentioned have noted the following. The involvement of local communities in the design and performance of activities is of paramount relevance to increasing the likelihood of community compliance. End quote. Rather than viewing community participation as instrumental, that is, related to compliance, I would argue for the following rephrasing, quote, the involvement of local communities in the design and performance of these activities is paramount, period. This is because they already possess the agency, motivation, and oftentimes local knowledge to address neglected diseases. There are examples to learn from. Reporting from southwestern Nigeria, Ajayi and colleagues note the feasibility of community-directed multiple interventions for poor urbanites in Ibadan, noting, and I quote, "Potential resources for the strategy abound in the communities." Can these community resources not be marshaled towards the development of strategies for neglected diseases? On a larger note, aren't we ethically bound to do this? If we were to meet this ethical obligation, it must be further acknowledged that these conditions are far from neglected in the communities where they occur. I suspect one of the first questions we'd be asked by the communities is why we've decided to call this program of work neglected diseases. In the Indian case, snakes have been part of the cultural ethos for centuries. They have been, and for some continue to be, an abiding and preoccupying concern in daily life, largely through forms of nature worship. Some of us have heard of Manasa, the snake goddess. Manasa has been worshipped by the advocacy or tribal community for generations, even incorporated into the Shaivite pantheon some 100 years ago. Not surprisingly, she is worshipped in the precise geography where snakes abound, Bengal to Andhra, Odisha to Himachal. This is also where the vulnerability to snakebite is greatest. Manasa is celebrated in the festival of Nag Panchami, which also, not by coincidence, falls during the peak season of snakebite vulnerability, July through August. I mean to say, now that snakes have been part of at least the seasonal imaginary of tribal Indians for eons, and other Indians increasingly, like my very own grandmother, at the very least, this is something older Indians may well recall and younger Indians may wonder about. Bearing this in mind, snakebite, at least historically, seems far from neglected by the community. It was a priority condition, or more accurately, a community prioritized condition. What can we learn from this history? Can this history be linked to current agendas for snakebite? What kind of policy traction would that have? I had a fascinating interaction with Dr. Gupt, our resident snakebite expert, who has sort of tempered my own enthusiasm around drawing lessons from communities. But he did say this. He does think that community health workers, in the Indian case, can build on their existing relationships to talk to people about snakebite, to bridge the gaps that we ourselves have created in communication around snakebite. As I've hoped to demonstrate here, using a social lens, which is done less often, admittedly, even in SDH work, forces us to shift focus and disrupt our discourse in critical ways. Another element of social determinants is an attention upstream towards broader ecologies and systems of relationships that affect us and our health. Some lessons are evident here in the work of Green Cross India, a concern of Jiva Karunya Trust in Tamil Nadu. This group heads the Indian Snakebite Initiative and frames the issue not only at the point at which envenomation occurs, but in the larger context of human-animal conflict resolution. Human-animal conflict resolution is based on the notion that humans and snakes occupy a shared and increasingly threatened ecology, where each poses a threat to the other. Jiva Karunya also works on sustainable livelihoods for tribal populations, environmental conservation policy, and youth activism for sustainable development. Thank you. Here we find health part of a broader agenda and an accompanying focus further upstream, concerned with an understanding of and greater balance in ecologies that may minimize our vulnerability to this and other neglected diseases. Certainly, I feel this could be a key area of future work and indeed of research as well, particularly as we make our way past the MDG era. This is where I'm getting a little controversial right at the end. Critical as it is, my view is that the work on universal health coverage, or UHC, falls short here. UHC cannot by design holistically address neglected diseases simply because that is actually beyond the purview of health systems reform alone. So rather than preoccupy ourselves with integration into a health framework or emerging UHC model, I would like to provoke us to think about what broader spaces this work can occupy. We have seen that where health issues aim to become high policy, they tend to sequester into vertical agendas of their own, sometimes to the neglect of other health issues. This tendency has been seen in the response to the HIV epidemic. We perhaps responded in the most sensible way we could then, as we always seem to have from era to era. But, mindful of the lessons of these earlier efforts, we should perhaps be thinking of a more upstream, nuanced strategy now, one that engages with health diplomacy. Manoj's work offers a lesson here. His work was in tobacco control, which is one of our rare examples of situating a health issue in much broader ecologies of thought and action. At a talk in Delhi yesterday, veteran environmental health scientist and Nobel laureate Dr. Kirk Smith from Berkeley was talking to us about the sheer volume of research on tobacco. There is also a range of work in this area: historical, anthropological, biostatistical, epidemiological, econometric, arts and communication related, political science related. Not only has this work involved so many disciplines, it has begun to transcend them. This richness has given practitioners a larger universe of options and indeed sphere of potential and actual influence. The latest development in this area in India is a budding alliance of researchers working on first-hand smoking, second-hand smoke, household air pollution, and outdoor air pollution. These 4 risk factors are attributable for a range of morbidities and mortalities that accrue in complex eco-social webs of causality. Could we picture such a trajectory for neglected diseases? Such an alliance? I think so. We owe it at least to Manoj's family, if not to release ourselves from the daily tragedies inflicted by neglected diseases. Thank you.
Thanks, Devaki, for wonderfully sharing regarding Manoj. I won't call it a case study, it will be an insult, I think. But bringing out, it happened to Manoj, who was at PHFite. What she shared, it could happen to each one of us, to our family. Health sector, many of the times when we look at numbers, it's somewhere there, but when it hits one of us or our family, that's where everything goes crumbling, the policies, everything, you know. I think that's what was wonderfully brought out by Devaki. And thank her for not putting it on a PowerPoint, because the entire thing would have just got lost. You don't tell stories through PowerPoint. All of us, and I think many issues have been raised by Devaki. I would now open it for the participants, but please ask for any clarifications that you may have. The debate can come. We'll have a later debate on broader issues. Yes, please.
First of all, I must thankful to the organizers for allowing me to participate in this program. Though I have not submitted my abstracts in time to the group, and mostly they have accepted to participate and interact with the group. See, my intention to relate to the Devaki Nambiar. In the past 1 month back, one of my colleagues, project staff, who was working in Uttar Pradesh, the Gorakhpur district, where the children are dying due to the Japanese sensibilities, brain fever, mosquitoes, which transmit the Japanese sensibility virus. Every year, thousands of deaths are being reported. You might have heard in the newspaper.
What is the clarification, please?
I want to add with her. One of my colleagues who went for the collection for the mosquitoes in the field, outdoor collections where the mosquitoes are resting. During the collections, the person was bitten by mosquitoes because he was collecting in a yard of bricks over that. When he was coming down the bricks, the bite was taken place and the buttocks, backside of his leg. But he thought that, he ignored that. When he come to the office, he fell down and with the unconscious. Immediately medical care was given and immediately antivenoms was given from the hospitals for 2-3 days, and he was in the intensive care. His life is saved. So the need is, you should also emphasize the group in a place where the infested snakes are found, people also should take care. Okay. Any kind of bite, it is an insect or it is a snake or anything. So, in such kind of things, since he had a good protective cloth, he has been escaped. That venom has not been. Okay. That's the thing I want to share.
Thank you. The point is well taken. Any other clarifications or questions to Devki? Yeah, Julie. I know your name, Julie.
Hi, thank you, Devki, for a wonderful and very heartfelt talk. I really liked your point that when you said that it's a community prioritized condition, and so it's not neglected condition. But I think you're talking about the local community, and I'm afraid that the global community, if we talk about more global community, has what has been neglected among the global community. So I wondered, in your experience, what's causing this disconnect, or what can be done about the disconnect between the local community, where it's actually a prioritized condition, and us or members of the global community who have up until recently been neglecting it. Thank you.
Gosh, this is, it's a half day's conversation that we could have, but very quickly, I would have to say that there is no a priori requirement for the discourses, the global discourse and the local discourse to match, because the audiences and the stakeholders are so very different. So in a nutshell, I would say that is the case. I don't have a problem with I think it was, as I mentioned, a very strategic choice to have the moniker of neglected diseases at the global level. That is a political piece there. But we must be very careful to not try to adapt or translate that at the local level, where there are preceding understandings of the situation. So I suppose we agree.
Any other thing? If there is no other question or clarification, I would request Dr. Werner to take over.
Thank you. Let me introduce Dr. Upendra Bojani. Dr. Upendra Bojani graduated as a dentist in 2002 and worked as such for a couple of years in Gujarat government service. In 2006, he obtained his Master's in Public Health from Deakin University, Australia, having studied under, amongst others, Fran Baum's colleague and sister-in-arms Ilona Kickbush. Soon after, Dr. Upendra joined IPH here in Bangalore, where he developed a project and a team that is revamping tobacco control in Karnataka state and in India as a whole. Now, you might ask what tobacco control has to do with neglected diseases. I kindly remind you of Professor Jacob John's definition of neglected diseases 2 days ago. Those health problems that the government does not want to control. Tobacco use clearly fits this definition, and Upendra's team is leading the way to change this. I thus welcome here my colleague and friend, Upendra Bojani.
Thank you, Dr. Sos. And sorry, Sunil, that I'm having a presentation, but not a PowerPoint one. So, and thank you, Dr. Sos, for explaining my misfit into this theme, because what I'm trying to do is, at Institute of Public Health, some of us have been working for over last 7 or 8 years, trying to reduce tobacco use in society. As he said, tobacco use is not a disease, but it is a significant risk factor for several diseases, which imposes quite a huge disease burden. Nearly 1 million adults die every year prematurely in India because of tobacco use. It's just not disease burden. If we consider the consumption expenditure that the families and people spend on tobacco, nearly 1 in 3 adults use tobacco in India. And also if we consider the medical spending, which is mostly out of pocket on tobacco attributable diseases, it is clearly impoverishing people. So in that sense, if I take a political meaning of neglect, then I feel that largely this issue has been neglected. So, but I'm not going to talk about tobacco. What I'm trying to highlight from our experience over the time, a very limited experience over the time in this particular domain, is to make 2 points. One, that policies in sectors other than health are very important and determine the health and well-being of people. And second, to draw upon some of our experiences to try to bring out few lessons on how to actually put addressing social determinants in practice, how it might look like. So let me try to do this task by telling you a few stories. Well, like many health promoters, I don't like to see health as sort of some optimal state of well-being to be achieved, but rather a resource for everyday life. And I would like to go back to a point that Fran Bohm made in her presentation about health in all policies or multi-sectoral action. What I would like to reiterate, and I think that is a question we should be asking us periodically, is where is health created? And I guess, of course, health is rather created out of health sectors. It's rather an illness care sector, as Amartya Sen puts it, because it's only when people get sick they come to us and we rather repair them like a mechanic. So where is health created? It's really about the settings and environments where people live, where people spend most of the time. And it's these environments that could be health promoting, or it is these environments that could enable people to make healthy choices and to make healthy choices as easier choices. So let's see within tobacco control, just because we have worked in tobacco control, but my larger point is to see how policies in various sectors have affected this issue of either reducing or promoting use of tobacco in India. So let's start with a transport sector. In 1988, Indian Motor Vehicle Act, which was a public policy to regulate public transport, very first time brought a clause saying that it restricted smoking in public transport, especially the state-led public transport. Now, of course, we do spend a lot of time traveling from home to workplace, from one to other place. In a subsequent year, Indian Railways, which is one of the largest employer in the world, made trains smoke-free. This was the time when there was already a law existing in India on tobacco, but that law was mandating only one thing, that is to write on cigarette packets saying that cigarette is injurious to health, but nothing more than that. But in India, having policy is one thing, and getting it implemented is quite another thing. So let me tell you, and let me briefly introduce you to Monamma. She is from Kerala. She used to teach English literature in a small college in Kottayam. She used to live in Kochi, and she used to travel every day up and down in a train. To put in her own words, she says that it was quite tiring to every day go up and down, and men in the train used to puff away and many times swirl the smoke to us. In those times, in 80s, working women themselves were a minority. And she was quite upset with that. What happened one day was her colleague, who was asthmatic, got fainted. She fainted in the train because of it was quite excessively smoky. And despite a lot of requests, the co-passenger didn't step away. And that really made her outrageous. She said, I should raise my voice. She went to court in Kerala asking that I do know that the passive smoking is harmful, but I really don't have choice because I have to travel to my workplace every day and I can't avoid my co-passengers. And in 1999, the Kerala High Court gave quite a landmark judgment to prohibit smoking in public places in Kerala, including trains, but many other public places. The court said that the Indian Constitution assures not only Indian citizens, but also the visitors to India right to life. And living life is not just a mere existence of the life. State must ensure the conditions where life can be enjoyed. And beyond that, the court also said that it's actually an environmental issue. They draw upon the Air Pollution Act of the time to say that in indoor environment, if you allow a lot of smoking, the air quality goes down. Court also mentioned about that it's a nuisance, it's a public nuisance, and it must be avoided. And 3 years after that decision in Kerala, one seasoned politician who used to be the mayor of the Mumbai city, who was member of parliament, Murli Deora, went to the apex court of the country asking the similar things. And so in 2001, the Supreme Court of India asked central as well as various state governments to make sure that they prohibit smoking in public places. It's interesting that it took 15 years after that transport policy that the health ministry came out with a comprehensive smoke-free law in India. Let me tell you another story. This is about gutka, G-U-T-K-A. Gutka is a chewing tobacco product. And it's readily available, it was available in small plastic sachets, as you see in the picture. Now, chewing tobacco with either areca nut or betel nut in India or even in South Asia is not new. There is a history of over 200 years. But it's nearly 3 decades that the commercial manufacturing of these products in the small plastic sachets started. And it became so popular because it's very cheap, readily available, and especially children took onto it. It's inconspicuous. When you use it, it's not like smoking. So you know, it really became the starter product for youngsters to get hooked to tobacco. And this was realized by few state governments. In 2001 to 2003, nearly 4 state governments in India banned this product. Using what? Using a food law called Prevention of Food Adulteration. It was another thing that the tobacco industry, which is quite very powerful, challenged the state to do so and was able to overturn the ban because the court thought that such a power to ban a product really lies with the central government and not with the state government. But the story took quite an interesting turn. An NGO in Rajasthan who was working on, the NGO working on health and environmental issues went to court in Rajasthan saying that plastic waste is choking the earth, is choking India. It's a big environmental issue. It's degrading our environment. And those small sachets of chewing tobacco are everywhere on the streets, nook and corner. And it demanded that the government must not allow these manufacturers to use the plastics in packaging these products. And very interestingly, the Rajasthan High Court used a very basic tenet of environmental policy in India, which is polluter pay principle. If you pollute environment, you have to pay, you have to compensate for it. And the court asked industry not to use plastics in making tobacco products. And that was quite a blow on the smokeless tobacco industry in India. Very soon after, the food policy was now amended in 2011, before 2 years, now enabling state governments to take action. And the moment it happened, one after another state in India banned tobacco under the Food Safety and Standard Act. Karnataka became the 26th state to ban tobacco. Let me tell you another story because the policies in all the sectors are not very health promoting, and let me talk about the agriculture or the trade policies in India. India is third largest producer of tobacco leaf in the world and one of the top exporter countries of tobacco leaf. Now, while the health ministry is doing all to reduce tobacco use, in last decade, the tobacco production in India has gone up by 20%. The central government, under the Ministry of Commerce and Industry, has set up a constitutional body called Tobacco Board of India. The sole mandate of this body is to promote tobacco industry in India and to promote the Indian variety of tobacco across the globe. It does all. It provides subsidies, it provides support prices to the farmer, and spend a lot of money to promote tobacco. Why so? Because in India, tobacco is still seen as a big source of revenue for the government. While the studies have established the fact that in India, the medical cost of treating tobacco attributable diseases is nearly 16% more than the total revenue generated. But then who has to spend on diseases? It's the people who spend out of pocket. And so governments still consider it as the major revenue source. But when it comes to taxation, there is a very mixed story. While it is very well known that the raising taxes on tobacco has a very positive impact in reducing the tobacco consumption, especially among youth. Only a state of Rajasthan has some significant amount of taxes, that's 50% of taxes across all the tobacco products. But then most other states have a very different story to tell. If I talk about Karnataka, we have 0 taxes on BDs, which is an Indian version of cigarette. And we have very meager taxes of 12 to 15% on cigarettes and chewable tobacco. Lastly, let me tell you the final short story about this photo. What you see in the photo is, in 2011, the President of India, then President of India, conferred Padma Bhushan Award, which is the 3rd highest civilian award in India, given by state, to a gentleman, Mr. Deveshwar, who was then and still is the chairman of ITC, which is one of the largest cigarette manufacturers in India, and it is a subsidiary of British American Tobacco, which is a big tobacco in the world. Let me highlight this political economy of tobacco. Tobacco industry and government have a lot of intertwining links, which makes it difficult and probably which lowers expectation of the state to take a health promoting stance. Before a couple of years, I was working on a paper to trying to know, and what I came to know is that the ITC, the company which is run by this gentleman, donated over 800,000 euro in a year to various political parties in India. It's not just tobacco industry. In fact, I saw that 6 out of the top 10 shareholders in one of the biggest cigarette manufacturing company in India are government-owned companies. Governments see tobacco industry as a very safe investment place. They want to invest there. Very ironically, one of the cabinet ministers in India who owns crores worth of tobacco industry, he's actually known as the tobacco king of a particular state in India, was one of the ministers appointed as a member of a group of ministers to draft the rules about tobacco control, how to control tobacco in India. So just I would like to highlight, these are the larger factors, the policies in different sectors, the kind of political economy that goes around really affect. Of course, this is not to say, so I mean, my point was to make this, that the health in all policies is not just in words. It's something that really affects health and well-being of people. With having made that my first point, let me start to move on to the second point. In second point, I would like to sort of bring out a few things. Now, let me clarify. I'm often told, that you talk about social determinants as if doctors have no role to play. I think healthcare sector has an important role to play, and in fact, there is a unique challenge to the health professionals to go beyond healthcare sector and become advocate to make policies in various sectors health promoting. Now, that is quite a different challenge than treating patients. And what I would like to do is that over last few years of work, I have met wonderful people, because such work is not possible without a team. And I'm happy that some of my colleagues are here. There is no other good example of health professional being an advocate for multi-sectoral work than my senior colleague, Dr. Vishal Rao. Thank you, Vishal, for being here. He is a cancer surgeon, operates on a daily basis on the cancer patients, but does much more than advocating for a good health services. Vishal, I would like to request you to share for a few minutes, just 2-3 minutes, your journey. How do you feel as a cancer surgeon working on many other sectors?
Hi, Upendra. Thank you all for giving me this opportunity. Okay, so I'll summarize my discussion in 1 or 2 points. First of all, the background about why I was pushed into this initially by my senior colleagues, and what gave us the background was, for cancer per se, I think in India we have about 10 lakh new cancers coming up every year. And if you look at the ICMR and other statistics, about 50% of these are because of tobacco. So for us, over the last 50 years, when we look at the SEER data, the end epidemiology data, we look at hospital registries, For cancer per se, when we look at treatments, hardly about 5 to 10% improvement in survival, or majority of the tobacco-related cancers, there's no improvement in survival. So no matter what amount of good chemo you give, what radiotherapy you give, or what amount of surgeries you do, the survival has remained the same. So if you have stage 2, you end up having a 60% 5-year survival standard. So there's no difference actually in terms of survival. So we often pondered about, because I worked initially as a surgeon, when I used to be very busy operating and trying to do the maximum number of surgeries. Second, looked at genetic research, tried to look at the magic bullet in angiogenesis and another genetic research. Towards the end, to understand that there's actually over the last 50, 60 years no change in survival at all. So the answer remains very stark and clear to us that there's absolutely only one magic bullet, that's prevention. So rest of all of these attempts are actually futile. So that sort of started getting us thinking onto, are we in the right track? And that's when I came across people like Upendra and organizations like IPH, who actually were doing a lot of work in the area of public health, and I kind of initially showed some interest to work together to see if we could do something together wherein we also exercise our interest and also to contribute into the area of preventive health, largely to impact science to a greater extent in oncology. So that's where my journey began, and with IPH, Upendra and a whole lot of our group grooming us, trying to understand it more analytically as to where we could do things. We started off on a journey in tobacco control, and today I think, like Upendra has highlighted this, we've come across a long way, including our health minister and greater champions coming across and taking lead roles. So today Karnataka is one of the only states in the country that has actually implemented the COTPA Act, the Cigarette and Other Tobacco Products Act, across all districts in Karnataka. And we become the first state in the country, and it's really heartening and glad to know that we've achieved this. I'll give you all a quick example of what went behind this. In November 2011, December, when I met the Home Secretary, asking him if he could implement this act and what are the ways in which we could do it, I still remember the government order was in our hands, and Mr. Jamadar was the Home Secretary of Karnataka, a very reputed IAS officer. He told me that this government order, which is being sent by the union government, he said is a good order, but he said, I can assure you that this cannot be implemented, this won't work. So he said, why are you all so keen about this? And I told him about the background about public health, about the issue of cancer, and I said, I think that this is something very relevant. That order was to ask the police to implement this law very strictly and add it into the monthly crime review. From that time till today, we have 3 IAS officers who have changed as Home Secretaries, and when I shared this last month with our present Additional Chief Secretary and Home Secretary, we've achieved all 35 units in Karnataka. That is, the 30 districts have been completely covered, and all 30 districts have been implementing. In the last month, they collected fines of 30 lakhs in Karnataka, which was a huge step forward. Now, what went along those 1 year, 1.5 years for Karnataka to start implementing, from a person, from a senior IAS officer, a committed IAS officer who told me that this government order can't be implemented. When we both sat and analyzed about this, we understood that government order in India is a little different from government order in many Western countries. So in a lot of countries, a government order, when it's issued, it means that it's implemented also. There is a process that has already been determined on how to implement this particular order. Whereas maybe in India that process may not exist. So largely it is just an order on paper which is circulated across the country, and everybody is asked to find out their own solutions. And that's where the problem begins as to how do you implement this. From when I still remember the Director General of Police to the Home Secretary, wondering what are we supposed to do, how are we supposed to implement the act, to today we are training every district to implement this act. So I think this was a whole set of revelations for us, but the one single message that came out of this for Karnataka was that if we can get, the biggest victory of tobacco control was to bring together the government, NGOs, the media, the judiciary system and the civil society together. If you can come together on a single platform, I think no industry, nobody can be invincible. And that's the very good message that we got out with, because Gutka ban was one standing example for where everybody came together to actually stand on the same platform, rather than simply sitting and blaming the government and telling that you can't be doing this, they have not done it. Let's all come together under one platform, work together, and show that by mutually not blaming each other but helping each other, we can achieve larger goals in this. Thank you.
So thank you, Vishal. I think it highlights what Fran Baum puts in her slides, how to implement health in all policies, where you have mandate, but then there you need structures and policies. So that's where you need police department, education department, health department working together at various levels in order to make a mandate come in a real. I will quickly like to go through, because this is an important advocacy strategy. The health promotion, they often refer to a word enable. So you need to enable and work with community to make sure that they are able to sort of represent their voices. I'm very happy that I have a wing commander, Mohan Raj. He was awarded the President's Award in his service, and he has spearheaded a movement called Voice of Tobacco Victim Movement, where the people who have suffered either from the active or passive use of tobacco have came together to sort of advocate for the health concerns. Mr. Mohan Raj, would you like to share? I would like to tell you only for 2 minutes, in a way, what has been your experience of being part of such a movement?
I can't speak much. I'm a victim of passive smoking, another neglected disease. Now, everybody knows the difficulties. The people are aware what active smoking causes. I was flying in Indian Air Force across the Himalayas, supply dropping day in and day out. Very strenuous job. Everybody was smoking. I never smoked. But I was not aware that there is something like passive smoking that can cause cancer. Thanks to Dr. Vishal, I am a survivor till now. But I speak differently. I breathe through a hole in the chest, and I cannot taste or smell, but life goes on. But the organizations to which I belong, like Voice of Tobacco Victims, has empowered me to take up this cause vigorously. We wrote to Bangalore International Airport, who were violating smoking ban. Immediately they took action. We wrote to the police. Now, as Dr. Vishal Rao said, lakhs of rupees were fined, and soon Karnataka bus stands and railway stations may become. So, what is needed is awareness about the neglected disease like passive smoking and empowerment through organizations. Thank you.
Thank you very much, Mr. Mohan Raj. He has been spearheading a movement of Voice of Tobacco Victims, interacting with ministers and senior political leaders from various ministries, and it has become a key force in changing the political sort of positions of government on some of these crucial issues. He has founded a global Larry Club. Finally, last 2 minutes, I would like my colleague Amit, who is a communication expert and who has been working very closely on media advocacy, to highlight what is the role that media play in reaching out to different sectors and molding and shaping the policies to make them more health promoting.
Yeah, hi all. Like normally when we talk about public health and when we talk about advocacy for public health, we feel that there is a need to sensitize the policy makers first. So it was a task which we took in hand, and we wanted to reach out to as many policy makers, as many legislators as possible, sensitize them about the issue, and make them on board, and take their help and assistance to take tobacco control a step ahead. So it is a story of one such policy maker which we met in due course of action. This person is a legislator from one of the districts in Karnataka. 2012 was a time when many states in Karnataka in India had banned gutka, and we were looking for different opportunities. How do we take this? How do we ban gutka in Karnataka? So we approached IMA and IDA, the Indian Medical Association and Dental Association. They readily agreed, and more than 1,000 doctors signed the memorandum, which was handed to CM. Post that, we did one press conference where we invited one of the legislators, and he came on board. You can see, he came on board along with the IMA and IDA representatives, and also the patient, who came and who spoke, and they asked for gutka to be banned. This legislator was from the opposition party. He was an opposition party, and he willingly supported the cause, and he said that this has to be done. The gutka has to be banned in Karnataka. After that, Karnataka had elections. The state elections were on. Fortunately enough, the party which was in opposition came to power, and per se the legislator who had come down to meet, to ask for gutka ban, became the health minister. It was so fortunate that we went to him and we asked him, see, you had asked the government to ban gutka, now you are in the power, why don't you take up this issue? He readily agreed. But as Upen had already told, we have industry here, and there are farmers, arcanine growers, who were like opposing to the ban, and he was telling that there will be a huge opposition from his own party people. So we took that opportunity. You can see that we created a lot of stories before the gutka was banned. We created story, we created a platform for him so that he can come in open and he can ban gutka. So once the gutka was banned, we gave him enormous publicity so that he takes this as a positive thing. It helped him to, for him to keep his stand firm on the gutka ban in spite of lot of opposition from the rest of the people. Now, just having said that, there was an order passed, but in India, it's always that once an order is passed, it is not, it doesn't come into action. So we had to make sure that we created some negative stories. It's like a week after gutka ban, still we find gutka in shops. So the ban was not very effective. So we started creating stories so that the ban was effective. And immediately after that, Vishal was called by the Home Secretary. He was called by the Health Secretary to discuss how do we initiate and how do we actually implement the ban orders. So this way we have used media not only as an awareness tool but also an advocacy tool. Not just for most of the health persons here, they feel that media means it's a awareness mechanism or awareness tool. But if we can use media much more tactically, we'll be able to reach out to the policymakers and get more out of them. Now the health minister actually walks down the road for us. He actually goes down to the shops. He along with the cops, and he's removed different advertisements, illegal advertisements for tobacco and things like that. So it has actually helped us to create a champion for tobacco control. Thank you.
Thank you, Amit, and I apologize for the delay and the taken. Thank you very much.
Thank you, Dr. Bajani, Dr. Rao, dear Mohan, and dear Amit. Before we go to a wider debate on social determinants and neglected diseases, if you have any questions for clarifications for Upen's team, this is the moment.
Good afternoon, one and all. My name is Santosh from MPH student, KL University, Belgaum. So one thing, what I have seen that after banning of gutka, that earlier only one sachet of gutka used to come. Now what happened? There is some separate sachet for pan masala and separate sachet of gutka. So earlier the cost of that sachet was 3 rupees. Now what happened? The cost is doubled. Now it costs 6 rupees. I don't know whether the number of users has reduced or no, but the cost has increased. And one more thing I heard that whatever the effect it was giving after chewing that sachet, now they are telling it is more effective than earlier, so that we can try some other flavors by adding some other companies' tobacco. So how much we have achieved in this by banning this one, gutka?
To quickly address your thing, as you yourself said, that the price of the gutka has nearly doubled. It's been nearly 15 to 20 years. Many health advocates in India are trying to ask for raising the taxes on tobacco, and the reason is to increase the price. It never worked. Because I think probably in the finance ministry chambers, health advocates were quite a minority compared to the tobacco industry representatives. But the side advantage of banning a product was that the product prices have gone up. I completely agree that the product is now available in a very different form, and that is precisely what the tobacco industry does. So in a language of maybe neglected diseases, tobacco industry is really a vector. It tries to find out different tactics to sort of find loopholes in the law. In a legal recourse which we are already pursuing, actually it is not possible to sell such products, and so to my knowledge many state governments are already in the consideration to revise the policy so that such products which still contain the raw tobacco cannot be made available in the market.
Upen, can I add a point to this? To answer this question again, like Upen said, this is more of a legal argument. The chewing tobacco gutka was banned under the FSCA 2.3.4, which said that no food product should contain tobacco or nicotine. What the industry is now using is they are saying that we are adding tobacco into food. We are not adding tobacco into food, we are adding food into tobacco. So they're kind of reversing the role and they're trying to argue this. So this is more of a legal question. And this today stands in Justice Singhvi's court, and it's, I think, another week for it to get answered. This precise question is going to be answered, and we're hopeful that this is going to be addressed very, very amicably. The second part is about reduction in consumption. Obviously, there has been a reduction in consumption. At least across the country, there has been studies conducted which show that there's almost 26% reduction in consumption of gutka. Now the reason for that is the moment you see a ban, a lot of us have this imagination that a ban means eradication. But I think a ban means the best level of control. It need not be eradication, but it's the highest level of control you can achieve in something. So from a point of view of consumption reduction, obviously, because if you look at youngsters today, a lot of them who did not know about gutka harm effects today know that for some reason it's been banned means it must be bad. And a lot of youngsters have reiterated the same opinion, saying that no, I think this is something bad. Even children, school principals, teachers, many people who have been talking saying that no, that's a banned product, don't go close to it. So that itself is a very good mass awareness program.
Yeah, and I think the larger point of the team's presentation was not really to dwell on tobacco control per se, but to really highlight, using our own experience, how the policies in different sectors shape the environments in which, in this case, tobacco use, but maybe in that sense, any other health conditions gets affected, I think. So that's why I try to avoid a lot of technical questions on tobacco, because I don't want to stall the time of the important theme on a very vertical issue.
Thank you very much for the very interesting presentation and also testimony as well. My question is, because of that, we say that there is different approach of doing the intervention. One is to stop what we call not demand side, but the provider side. This banding is from the provider side. This can be done at some point, but however, because there is some kind of what we call an unofficial or unseen marketing market that can be still sell the product which not in an official or unseen setting. I just would like to get some kind of clarification from you whether there is under the table selling all these products as well.
Sorry. No, I think I really couldn't get the entire comment. Was it about, can you help me?
Could I request you to please repeat the question, just the question, and
is there any, any, because you can sell under the, in a unseen, yeah.
Okay, I think so. Well, yes, the black market does come up, and that's where I think many times health promotion is critiqued. As recently there was an issue of a journal where the people who actually participated in Ottawa conference, where the Ottawa Charter was drafted, considered to be a foundation of health promotion, reflected back on these many years. And one of the critique was that the health promotion is getting very bureaucratic. Are we only talking about health promotion at policy level, and where is community within that? Because community participation right from Health for All has been a critical component of this. Now, of course, in fact, many attempts at supply side things have led to the same thing, that if you don't reduce the demand of the product, then there is no point in because there will always be some other way that the supply will be resumed, either in legal or illegal ways. So I think in that sense, while in India tobacco control is going very strong, and people talk about some progressive steps, when you talk about in larger public, in community, how do they perceive tobacco use? I think there is little work that has been done in that sense. So I think somewhere I blame it to the lack of engagement with the direct community on many of these policy issues. So the progression happens quite fast on the policy angle as an opportunistic progress, but then it's not really the progress envisioned by the community as a whole. It is rather specific professionals who move forward.
Thank you. I think we have time for one more question of clarification. Severine?
Yes, thank you. Thank you for this presentation. So I know it was not directly related to tobacco use, but I was really interested to know what are the social health determinants, the social determinant of health of the use of tobacco in India.
Well, yeah, actually there could be many, but and it really depends. But I think the things like overall stress. Now the stress itself, you can go into the causes of causes, and then it could really lead you to the quite number of factors which leads to stress. But that's one important factor. I try to briefly highlight the political economy, where what kind of economic and political interests are at stake, and how they benefit throughout this large trade. In fact, if you see the global picture, the big tobacco, the larger corporations are actually shifting their bases to Asia, because here still we don't have stronger policies at that level. So I think there could be many factors, more importantly the political and economic factors. Of course, in India, the tobacco has been very much a part of social customs. So, I mean, these are sort of the larger issues that shape the use of tobacco.
Just one or two sentences to that. Which countries are the biggest consumers of tobacco? China and India. Which country, in that order? Which countries are the biggest producers of tobacco? China and India, in that order. So production of tobacco is a social determinant of tobacco use in the country quite profoundly. This is connected to our colonial history and larger political economy issues that Upen was talking about as well. And I think something that FCTC2 is really starting to look at with particular a push from the Indian case is to really look at the upstream determinant of production. We've looked at marketing, we've looked at point of sale issues, But what about production? I mean, you may have seen in the articles that Upen was showing that much of the resistance to the ban on gutka was coming from Congress MLAs who live in areca nut growing areas where the production is happening. This is a threat to them. We have to address that determinant.
Okay. Before time runs out, I think it's high time to come back to the broader social determinants on health and to have a debate on this. We had thought to do this based on two questions. The first question is a question that Professor Van Baum passed to us, and anybody who has an answer to it, please come up. The question is, why is it that despite all evidence, so little health policy focuses on social determinants of health? Answers can come from you, answers can come from or to invited experts. So why is it that despite all evidence, so little health policy ultimately focuses on social determinants?
Okay, so I may not have a sort of evidence-based response to this, but I have an experience-based response for this, which is actually not my own. I have to credit a Thai policymaker for talking to me about her vision of health in all policies. So there's one way of thinking of health in all policies where you have health in the middle and all policies have to deal with health. So your Minister of Finance should be thinking about health. Your Minister of Environment and Forestry should care about health. But she said, we need to turn that on its head a little bit. Health needs to go into all the policies. Isn't that a more respectful and appropriate way, an incremental way for us to proceed? And I was very struck by what she said, because I think if you take the analogy of a sort of a high school situation, trying to get everyone to converge on health is like you wanting to become the popular kid, the health kid, and everyone listens to you. But what about becoming the reliable kid? The person that others aren't threatened by, but that they actually come to because you can contribute to their agendas, you can contribute to their work. And I would suggest that the reason why so little policy focuses on SDH is because we haven't really figured out how to do that. And also, that looks very different in every case. And so I think that's the work ahead.
Okay. Thank you, Devki. You mainly describe how nice it would be if it would happen. Any idea why it doesn't happen, Upen?
Well, again, not an evidence-based response, but my own perception over the time is that when you say health sector, I think it is largely healthcare sector. That's how the health sector is made up of. And so I don't think that a lot of players in health sector really think beyond healthcare, while most of these determinants lie outside. And second, I think when it comes to policy making, health is not really a political agenda. I think in last few years, I do see now that health sometimes pops up in debates of political parties or in a political debates, but that still comes up in nature of health insurance schemes, largely because they are seen as kind of a very popular welfare measure. But otherwise, I don't think that health has even become a kind of an agenda among the political discourses.
Any ideas from our delegates on the same? Yes?
Hello. I had a somewhat broad comment to make, especially listening to Dr. Frombaum's and then Devki Nambiar's presentations. I felt like there was an essential conflict between a socialistic approach and, forgive me, the intellect that the elitism that accompanies intellect and education versus a more capitalistic approach that maybe looks at individual cases, that allows small approaches that come oftentimes from the communities to flourish. And I wonder, and I mean, I guess Upen and Dr. Vishal Rao and Amit and Voice for Tobacco Victims have demonstrated how health needs to be placed within the system. And I wonder sometimes if the attitude of the health professionals itself is one of the reasons why, since we see ourselves really as health deliverers rather than simply enablers, and if that might be a barrier in how, in just why, answering the question that you've just raised. And I would be interested in, hearing comments from all the panelists about, the thinking that goes along with how health is delivered, and in particular this division, this ideological division. Thank you.
Yes, thanks for bringing back to ideologies, because that would be the basis for major policy making. Yeah, I would agree to a certain extent that, but I wouldn't really put it in that context. I think one needs to really look at even our own work as researchers, documentation, practitioners. We all operate on silos. You look at the various health the departments in the government. Health department has nothing to do with the water supply, nothing to do with the nutrition. Though we talk about convergence in our own country, in India, we are supposed to have all kinds of committees and all kinds of things where all the secretaries and various people come together, but it doesn't happen. Forget the government. What happens in our own institutions? Someone is focused on tobacco, is just looking at tobacco, doesn't look at what happens in TB, malaria. Somebody is working on health financing, very much focused on health financing. Somebody working on human resources. We all are operating on our own silos. So I think it's a broader question about how do you really look at. But at a practical level, also it is important to note how many areas can really you work on. One needs to have that broader vision, broader approach, but then one needs to also focus in that context. I hope I've answered, and one I would like to.
About 2 weeks ago, I read not an article, but a 20-page policy brief made by a Washington think tank, which was commissioned a job by the American Association of Public Health on how to translate social determinants for US politicians. And they came quite close to what you state here, a kind of polarization between socialists and capitalists. I don't think that is useful. They came to the conclusion that to convince both Democrats and Republicans, you had not to use the term social and not to use the term equity. Well, I might not look so, but I'm quite an optimist. I still think that it is possible to talk equity in health circles, and that there is not really a need to call that socialist or anti-capitalist. You might indeed have a problem here in India, where a lot of your top economists and top politicians think that future depends on economic growth. So there might be a problem, but not such an irreversible problem, and not really a reason to bring it down to these kind of things. I do think that putting equity in health is still possible in India. But let's go maybe to a more provocative second question, and the more provocative guy on this board is the chair.
No, not provocative. It's something which is troubling me. And it also goes back to the history of healthcare. If you look at Europe and other countries which have really kind of eradicated or controlled certain diseases or illnesses, it has been due to more about public health care measures. And somewhere I feel that, and after hearing the panelists, social determinants and the intervention from that young lady, my own understanding, and then this health department, this medical, we keep on saying do this and do this, and keep on breaking our head with this. health systems, we keep changing the flavors of the month, you know. Now it is universal health coverage. Earlier it was health system strengthening. Before that it was primary health care. Before that it was health for all. You know, all this we keep, I feel if you really want to address the diseases, especially of the poor, the neglected disease, and I think let's forget putting more money, resources on this thing called health systems. You know, let's just shift the entire thing, close down our health ministries, or, you know, relegate them to some kind of archival departments and put more resources on social determinants of health. Does everybody agree with that? Great. She sits next to me, that's why she agrees. Second. Fantastic. So those who don't agree with me, why? Yes, Deva. Now you can't say, see, the audience, the participants, you have to take a stand, either this way or that way. You can't be sitting on the wall. Eh? Two people have taken position. You also.
I feel that it's not a either or. Huh? You need to address the social determinants of health, but you also need the health services. Somebody said, I think it was Preeta Menon, who said, build toilets and most of your problems will be solved. Yes, many of the problems. But what happens when you have a diabetic, got infected toe and you need a amputation? You still need your health service, right? So it's not, it's very, I mean, simplistic to say that if we do this, everything solved. And I'm challenging because I was an activist and I also was thinking that yes, if we change the social determinants, everything will be solved. But 25 years later, I realized that changing the social determinants is not so easy because power that to change are held by certain people who do not want this change. If we can spend millions of dollars to send a satellite to Mars, why cannot we spend that money to build toilets? It's not because we do not have the resources. It's because we do not want to build the toilets. We want to keep the people where they are. And that is what we have to address. It is not toilets, it is the power that we have to look at. That is the issue. Thank you.
Myself, Nayan Chakraborty, I work as a faculty with Public Health Foundation of India. I think I'll very much agree to what is coming up. I think one of the most important things that is coming up is most of the neglected disease that is so strongly related to the power relationship, the relationship that we share within household and outside the household. I'd like to bring two more incidents where there is so much of morbidity and mortality. One is the suicidal deaths and the road traffic injuries. The suicidal deaths, so the kind of people, those who are getting affected by the suicidal deaths of, so these are mostly these are women, powerless women that too living in the rural setup. Their primary occupation is agriculture. So these are the people, sets of people, those who are like, are very less powered in when you look at as a society or within the household.
Do you think more resource, the health department should be closed down and put more money into social determinants of health or not? That is the question.
Yeah, but end of the day, it's all about the different kind of power relations for whom you're talking and who is there inside the room.
Sunil, who gets the SDH money then?
Huh?
Who's there? Who's going to get it? Are we going to give it to other departments then?
Yeah, I'll answer that question later. Let him answer. Yeah, go ahead.
I think this is a series of exchanges that really lead all into the same direction. I had exactly the same reaction. If you're taking it away from one, let's say, government department, to whom are you going to give it in order to influence the social determinants of health? And I think one of the most powerful words I heard in a couple of minutes that went before is the word, I think Deva started it, it's about power. And actually, when I read the Commission's report on the social determinants of health, this is the one and most important thing that struck me, that for the first time in, I think, history known to me, an official body proclaimed that health differentials are largely due to power differentials. And that they are not only due to power differentials, but to power in the sense also that people have control over their own lives. That is one of the major, as far as I understood it, this is the major social determinant of health. And we can try to apply this to health services, we can try to apply this to living conditions, etc., but it all boils down to the same thing. What is your pecking order in society? Maybe that is not the only thing, but how much control do you have over your own lives? Now, if this is about power, I think this answers also your first question. Who has any interest in changing the power relationship? If this is not the case, I think the message from the report is a very strong message about power, but it is also at the same time pointing out an extreme weakness, because power does not change so easily. Or the power relationships and the power positions that people have do not change so easily. It can only happen if it does happen in a more or less incremental way. So this is going to take a long time. This is going to be a very long road. And it does not necessarily seem to be that there is strong leadership for this. So, in spite of what I may look at, I'm not so optimistic.
Thank you. Anybody else?
Thank you. Well, I just wanted to react to the last thing that he said. I think there is very strong leadership at the global level, only it takes us into the opposite direction. I'm a European and I'm scared if I see that all the things that we acquired are being broken down by changes in power, absolutely, and power relations between continents, and that we are being forced against what we in the end want to abandon a certain equity that we were able to construct in our health services, not so important indeed, but in our society.
Julie?
Thank you. Just a very quick comment also to react to the last couple of comments. I think it's wonderful that we are...
Please, can you speak loudly?
I think it's great that we are talking about these issues of power and agency and so on. I think my only brief comment is that I think we tend to think of power as one sort of type of thing, but there are different types of power and different ways to get to power and different understandings of what power is. So I think maybe even as researchers we can start to think about that and how that's related to social determinants of health.
Just I want to say that I do agree that the social determinant is very important and we have to emphasize because, as you said, the power. But as you see, it's not only this is our role in in the health sectors, if I could say sectors, because also this one is coming with the different definitions, what you talk about the health sector. But this is not only the roles of us like the providers, but we have an important role that we have to play, and that we have to strengthen our health systems and we have to deliver. And this is what say that we have, as a providers, have a role to address the social determinants and to address that, because it's not easy to change these power things, but also at the same time, this is our mandate, that no one can do it other than us, that to improve our system to deliver things. And this is what I could see that how it will be.
Can I make a point?
I would like
one last
slowly
point
to round up if possible, because our time
Girl,
is...
young lady is there.
Okay,
She sits
let's go
next
for
to me
two more.
every day. She has to.
I just wanted to carry on this idea of power and how we see that health does not have power, because we consider health as an end and social determinants of health as means to that end. But we could always reverse this by looking at it in another way. In the sense, we look at health as a means to other ends, like better education or better livelihoods or many other things. So once we start looking at health and marketing health as a means to many other goals of a good life in a population, then surely we're having more power than what we think we have. Does that help?
Okay, now.
Yeah, hello. Yeah, the same point I wanted to make. I think we were discussing here in this point more about we are talking about this like cause and effect. So it's like treating fever and not treating the cause of the fever, like malaria or something like that. So I think here social determinant becomes the cause, and the effect of which is all of these. So primarily I would agree that the focus largely needs to be on the social determinants, but not forgetting the effects. We need to somewhere also treat the effects of it.
I heard you, but I'm not sure that everybody did.
Okay, good.
Let's slowly round up. Since Social Determinants report came out in 2008, I've heard very respected colleagues of mine talking very frustrated about it, telling me, okay, this is all fine and well, but I'm not good in building toilets. I'm not good at giving people decent work. I'm a healthcare provider. Now what can help, and where we have power to change that power relationship, is in making a difference, I think, between the determinants of health, which are indeed difficult to influence by us, service providers, and determinants of health inequities, where we can start at least to make our health systems and health services more equitable, and giving the example, which brings us all the same slowly to the theme of tomorrow. If you want to strengthen health systems, let it then please be in an equitable way that will go a long way to improve the social determinants of health. Mr. Chair. Up to you.
Thank you, Werner. I think time has come to wrap the session up. This question came about, I think we have the question about health vis-a-vis social determinants and all this. Yeah, there is an important issue of power. There is no denying that fact. But also the last, what Fran provided, if you look at what happened in Brazil, the difference in terms of the various rates, in terms of the conditional cash transfers, that may had a larger impact. So one really looked at what is it that's really making that change, making that difference. One is really, and for me personally, hearing from the panelists, listening right from the broader issues to sharing of experiences, sharing of certain issues was an important thing, and I think this was a different session. It was not the usual PowerPoint and reading out English, but it was really good to hear actual experiences, and that's where it really touches each one of us. because finally, as I said earlier, when it hits you or your own family members, then it's really, you really start wondering what is policy, what is health system, what is health financing. I would take this opportunity to thank the panelists and my co-chair for really conducting this session and really opening up the issues. And I think we have something to take back home from this session. Thank you very much, and I would like my co-chair to this thing. We shake hands. You have anything to add? Thank you. No, he's finished the thank you. So thanks a lot. And now I hand it over to the organizers. Thanks to both of you.
Yeah, I think before we close the session, I would just like to remind you that we heard Professor Fran Bohm through video, and in the evening, throughout the night, you are welcome to put any comments, any questions to Fran Bohm in 3 ways. Either you can go to Colloquium website where there is a blog, you can post it there, or you can go to Colloquium Facebook page where a post has been created, so you can make a comment or raise a question there. Or very simply, you can move out of the meeting room where you will see whiteboards with some sticky pads, yellow color. Just write down and stick it over the whiteboard, and somebody would post on your behalf to Fran Bohm. Thank you.
Thank you all. I would like to first start by thanking Dr. Upendra Bojani for the presentation describing how policies outside of health sector affect health and such mechanism has been neglected. I thank the whole of tobacco team for being present here amongst us and sharing their experience.
This is within the family.
I now thank Ms. Devaki Nambiar for her narration of the case study, bringing forth the failure of health system to tackle snake bite cases, which are the neglected among neglected diseases, and the importance of community awareness in this direction. Thank you very much. I thank Dr. Werner Soers for effectively co-chairing the session and for the questions raised. I also thank, last but not the least, I thank Mr. Sunil Nandraj for effectively chairing the session. I thank you all for your kind attention and the contribution to the discussions. Feedback cards have been placed on your table, so please do fill in the feedback and give it back to us. A few other announcements. Tomorrow's session will start at 8:45 a.m. here. All are invited to the social dinner tonight. That will start at 6:30 p.m. and is arranged in the lawn next to this hall. For guests staying in Ibis, travel arrangements are made at 8 p.m. tonight after dinner to go back to Ibis. You'll have to assemble at the entrance to catch the vehicle which will ferry you across to Ibis. We request guests staying at Ibis who plan to leave tomorrow to check out in the morning before coming here. You can bring your luggage here, and we have a room, separate room arranged where you can put up the luggage. Thank you all.